Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar and today we're going to discuss an important topic for your NEET PG exams. The important topic today we're going to discuss is the how to read an X-ray in your exam when they present with a bone lesion. Right, nowadays a lot of image based questions are coming. You're getting at least one tumor question in every paper, so therefore you must understand how to read these bone tumor lesions and how to come to a diagnosis. Many times the diagnosis is given away straight away in the clinical vignette. However, if you do not get or you do not come to the conclusion of a diagnosis, you have to look at the X-ray and then start reading the X-ray and finding out the type of lesion and what treatment you have to give if it is a two-step question. So how do you go about reading an X-ray? So there are various things that you have to look for when you're reading an X-ray. First thing is you look at the location of the bone in the body, like what kind of bone it is showing. Is it a flat bone? So what do you get in flat bones? You get in the scapula, in the pelvis, you get what is called as chondrosarcoma. Right? Chondrosarcomas are more common in flat bones. Ewing sarcoma is more common in the pelvis. So you should look at it whether it is a flat bone. Number one. Number two is long bones. Most tumors are common in the long bones, like the osteosarcoma, osteoid osteoma, osteochondroma, etc. So most of the tumors occur in the long bone. Okay. What are the tumors that occur in the small bones? What is the most common tumor in the hand bones? It is the enchondroma. So you must remember enchondroma, which is the most common tumor in the small bones of the hand and the feet, and it is a chondrogenic tumor, right? And you must keep this in your mind when they mention of bones in the hands and feet and smaller bones. What about the spine? You have many things, many tumors that can go in the spine. The most common tumor that can occur in the spine is a metastasis, of course, in the vertebral body. You can have multiple myeloma. Then you can also have the hemangioma that can occur in the vertebral body, where you have a jailbreak kind of sign or prison sign or multiple striations like this. This is called as an hemangioma. In the pelvis, you have multiple common tumors because the flat bone chondrosarcoma is common. You can also have chondrosarcoma is common. Then you also can have chordoma, which is an extremely malignant tumor, right? And which has a pathognomonic feature. What is it called? Ficelliferous cells. Ficelliferous cells. So first thing, that when you look at an X-ray, look at it with what type of bone it is. Is it a flat bone? Is it a long bone? Is it a small bone? Hands and feet, distal radius. So look at the type of bone that they are presenting, and then you can 50% of the work is done, and you can narrow down to which are the tumors or lesions that you would like to diagnose. The next thing that you should do is location within the bone. So the location within the bone can be both longitudinal. So let us say this is the tibial bone. It can be both longitudinal, that is, it could belong to the epiphysis, it could belong to the metaphyseal region, or it could belong to the diaphyseal region. One thing to remember is most tumors are metaphyseal, so it is important to remember the epiphyseal and diaphyseal lesions, and then the rest of the lesions are automatically metaphyseal. Then you should also look at whether it is in the transverse direction, whether it is in the cortex or is in the medullary canal and involving the cortex as well. So you can, location within the bone can be classified based on the longitudinal location, that is the epiphysis and the metaphysis, then the diaphysis. As I said, metaphysis, most of the tumors are in the metaphysis, and therefore you can remember the epiphyseal and diaphyseal tumors alone. It could be the medullary or cortical involvement based on the transverse location in the bone. Right, so let us look at the location based on the epiphysis, metaphysis and diaphysis. Diaphysis, there are three tumors. One is a fibrous dysplasia. Right, fibrous dysplasia occurs in the diaphysis. Ewing sarcoma occurs in the diaphysis, and osteoid osteoma also occurs in the diaphysis. Cortical bone, this is in the cortex. These two are in the medullary canal. So fibrous dysplasia occurs in the diaphysis, Ewing sarcoma and osteoid osteoma also can occur. The fourth tumor that can occur is called as adamantinoma. Adamantinoma. So there are four tumors basically which occurs in the diaphysis: fibrous dysplasia, adamantinoma, osteoid osteoma and Ewing sarcoma. Right, most of the other tumors occur in the metaphyseal region. For example, simple bone cyst is also called as unicameral bone cyst. This occurs in the central location in the metaphyseal region. If this kind of a cyst occurs before the growth plate closure in an eccentric fashion, it is called an aneurysmal bone cyst. So simple bone cyst occurs in the metaphyseal region, which is concentric or centric in nature. ABC or aneurysmal bone cyst occurs eccentric in nature, and both these tumors occur before the epiphysis closes. Enchondroma occurs in the metaphyseal region. Chondromyxoid fibroma occurs also in the metaphyseal region, and non-ossifying fibroma also in the metaphyseal region. And of all the major tumors, the most malignant and the one that occurs is devastating is osteosarcoma, which also occurs in the metaphyseal region. And before the epiphysis, growth plate closure, if you have a lesion in the epiphysis, then it could be most likely chondroblastoma. What is distinct about chondroblastoma in histological appearance? You have this chicken wire appearance in the histological appearance, and this is seen in chondroblastoma. After the fusion of the physis, where you have the giant cell tumor. Giant cell tumor and ABCs are difficult to differentiate. Before the closure of the physis, ABC is a higher chance of occurring. After the closure of the physis, a lesion starting from the metaphysis and extending into the epiphysis is a giant cell tumor. So after closure of physis or growth plate, it is giant cell tumor, and before closure of physis, it is ABC. Both the tumors are eccentric in nature. So let us have a recap. What are the diaphyseal tumors? Diaphyseal tumors are adamantinoma, fibrous dysplasia, osteoid osteoma, and Ewing sarcoma. Whereas epiphyseal tumors are chondroblastoma, giant cell tumor, infection, and a couple of other very rare lesions. All the other lesions usually occur in the metaphyseal region. In this video, we are not going into detail about each of these tumors. That will be done in another video. Right. The third thing that you have to see, first, now you have seen what type of bone is involved, number one. Second one, you have seen at what location in the bone it is involved, whether it is epiphysis, metaphysis, or diaphysis. And the third thing now you see in the lesion is the zone of transition. The zone of transition is how clear the demarcation is between the tumor and the normal bone. If there is a clear demarcation between the tumor and normal bone, it is probably benign in nature. Okay, so when you see this arrow mark here, there is an increasing malignancy or increasing aggressiveness of the tumor when you go from this end to this end. This is the least malignant tumor, where the body has walled off the tumor, or the normal, the junction between the normal bone and the tumor is very well demarcated with a sclerotic margin. So there is a sclerotic margin here. It's also called as a geographic lesion. And the lesion is well walled off between the normal bone and the tumorous bone. Here also you can see that the lesion is well circumscribed, but there is no sclerotic margin. This is also called as a geographic lesion without a sclerotic margin, and this is also benign, but it's a slightly more aggressive than this version, right? Then the next one, you can see that there is a geographic lesion, or there is a lesion but there is no clear boundary, and this is the next step in the sequential progression of the tumor in case of an aggressive tumor, where this third lesion is more aggressive than the second one. Then here you see the next we come across what is called as a moth-eaten appearance, where there is no clear demarcation. There are some big cavities, but they become smaller and smaller when they go away from the main lesion, and this is called the moth-eaten appearance. The most aggressive of all these tumors is called a permeative tumor. Where you cannot see a large cavity, you can only see small punched out lesions, and the tumor seems to be very aggressive. There is no demarcation between the normal bone and the abnormal malignancy, and so this is the most aggressive form of the bone tumor, and this is called a permeative lesion. So next, the third thing that you see is zone of transition. In the zone of transition, the following are the different types of lesion that you can see. The first one is the geographic lesion with a sclerotic margin, a geographic lesion without a sclerotic margin, a geographic lesion with a diffuse border, with is not no clear demarcation between normal and abnormal bone. Then you have the moth-eaten appearance, where you have a large lesion and there is no demarcation between normal and abnormal bone, and there is a small punched out lesion away from the large lesion. Then you have the permeative, which is the most aggressive and most malignant of all bone lesions, where there are only punched out lesions without any central large lesion. So let us look at a few examples of these conditions. Here you can see this geographic lesion, and you can also see very clearly the sclerotic margin. In all likelihood, this is most likely a benign tumor. So this is the picture that is depicted here, which is showing a geographic lesion with a thick sclerotic margin. The body has been able to wall off the tumor, and there is a good demarcation between normal and abnormal bone. This happens in fibrous dysplasia, cortical defects, and some other benign lesions where this kind of a picture can appear. Then you have this picture where it is moth-eaten in appearance. There is probably a large lesion, multiple large lesions here, and then are smaller punched out lesions, and there is no clear demarcation between normal and abnormal bone, and there's probably a pathological fracture here as well. This is the next or the or more aggressive form of the zone of transition that is seen in bone. And the last one is or the most aggressive form of this is the permeative lesion, where you have multiple small lesions. There is no clear demarcation between the bone, normal bone and abnormal bone, and this is the most aggressive form of bone lesion, and this is the zone of transition having the worst prognosis, and this is most commonly seen in osteosarcoma and other malignant bone tumors. Okay, so now you have seen, the first thing you have seen is what is called as the type of bone that is involved. Is it long bone, short bone, bones of the hand, bones of the spine, and bones of the pelvis? The second thing that you see is the location of the tumor in the bone, right? Whether it is longitudinal epiphysis, metaphysis, and diaphysis, or is it transverse in the cortical or medullary canal. The third thing you see is the zone of transition, which you have described so well in that previous picture. That is from the geographic lesion, which is the least malignant or most benign, to the most malignant, which is the permeative lesion or moth-eaten appearance. The fourth thing that you have to see in an X-ray is the matrix. What type of material is the lesion made of? If it is ground glass appearance, then it is called as a fibrous dysplasia. It is seen most commonly in fibrous dysplasia, that is a ground glass appearance. If there is bone formation or it becomes osteogenic potential, then it is most commonly seen in conditions like osteosarcoma, Ewing sarcoma, and other tumors. So this is called as an osteogenic pattern which is seen. The next pattern which is seen is called the popcorn pattern or the chondrogenic pattern, where you have speculated calcification in the comma fashion and in a popcorn fashion, and this indicates a chondrogenic tumor, very commonly seen in enchondromas, chondrosarcomas, and any tumor associated with chondrocytes and or chondroma formation, or it's called chondrogenic, and they have this typical feature called as popcorn calcification. Typical feature called as popcorn calcification. So after seeing these four things, the fifth thing that we see is a periosteal reaction. So the fifth thing or the fifth criteria that we see is called the periosteal reaction. If you see, any bony lesion will cause periosteal reaction. There will be a growth or elevation of the periosteum. For example, in infection, the pus enters between the bone and the periosteum and elevates the bone, and this is called as the subperiosteal abscess, and you can see a periosteal elevation in some conditions like the infection. An injury to the bone can also cause stimulate bone formation from the periosteum and cause periosteal elevation, periosteal reaction. If this periosteal reaction happens in a lamellated form, that is, it forms in multiple layers, then it is called as a lamellated appearance of the periosteum, and this is seen in the Ewing sarcoma. Lamellated appearance of this thing is seen in the Ewing sarcoma, where the bone tries to cut off the tumor from the rest of the soft tissue or rest of the body by forming multiple layers of the periosteum, and this is called a lamellated appearance of the periosteum. Then you have the hair on end appearance, where the tumor tries to grow through the periosteum, and this causes a hair on end appearance of the periosteum, and this is commonly seen in osteosarcoma, Ewing sarcoma. It is not specific to any tumor. It can occur in any malignancy. Then you have what is called as a sunburst appearance, which is the next more aggressive stage after the hair on end appearance, and this is also seen very commonly in osteosarcoma, but can also be seen in other malignancies. Then we have the Codman's triangle, where in a fast growing tumor there is not enough time for the periosteum to form a layer, and the periosteum is just elevated off from the bone with new bone formation at the corner, and this is called as a Codman's triangle. Is commonly seen in osteosarcoma, can also be seen in Ewing sarcoma and other malignant tumors, but most commonly classically seen in osteosarcoma, but not specific for it. Okay, so this is called as Codman's triangle, where there in a fast growing tumor the periosteum is elevated. There is no time for the periosteum to grow and heal nicely and to form layers or to form new bone properly. So therefore they just get elevated, and this forms a triangle of new bone formation there in fast growing tumors, and this is called as a Codman's triangle. So far we have seen 5 characteristics that we have to see about a bone lesion. The first one is the type of bone involved, right? The second one is the location in the bone, right? And the third one is the periosteal reaction, right? And the fourth one is the zone of transition. The fifth one is the type of matrix produced, whether it is ground glass, osteogenic or chondrogenic. Next, you look at the size. There are some tumors which differ depending upon the size of the tumor. If we have to differentiate between osteoblastoma and osteoblastoma, they both are histologically the same, but a tumor or a lesion or a nidus less than 2 centimeters. A nidus less than 2 centimeters indicates osteoid osteoma. A nidus more than 2 centimeters indicates osteoblastoma. So this is something that depends on the size of the tumor. There are other tumors also which depend on the size, but the most common example and most common thing that will probably come in your NEET PG exam is the size difference between the osteoid osteoma and osteoblastoma. The histological appearance is the same, as I said, but their size or nidus differs. Less than 2 centimeters is an osteoid osteoma, and more than 2 centimeters is an osteoblastoma. The final thing that you have to see is what type of cortical involvement is present. See, so if you can see, this is a scallop. This is an example of a scallop. It is a sea delicacy, seafood, right? And you can see how it is going in nice curves, and this is called the scalloping. And you can see that the tumor is also going in nice scallops. So it is not broken through the cortex, causing a periosteal reaction, or it is not malignant enough to break through the cortex. So therefore this indicates a benign tumor. Endosteal scalloping kind of indicates a less aggressive tumor, right? Then you can also see pathological fracture with the cortical involvement. Here you can see that there is some kind of lesion here, and because the bone becomes weak, it can cause a pathological fracture. Pathological fracture can occur following infection. It can occur following tumors as well. So basically that's how you read the bone X-ray or radiograph. So you break it down into 7 things using the clinical vignette. If you can look at these 7 things, you will straight away have a diagnosis. So the 7 characteristics of the bone that you would see is the type of bone involved. Is it long bone, short bone, flat bone? Is it the spine? The second thing that you would see is the location in the bone. Is it epiphyseal? It is metaphyseal, diaphyseal. Metaphyseal are most of the lesions belong to the metaphyseal region. So in the diaphyseal there are 4 lesions: Ewing sarcoma, osteoid osteoma, adamantinoma, and fibrous dysplasia. The third thing that you see is a zone of transition. Is it a geographic lesion with a sclerotic rim? If it is a sclerotic rim, it is a benign lesion. And or is it a permeative or moth-eaten, where there is no transition between the normal and the abnormal bone? This indicates it is a more malignant lesion. So the third thing that you will see is a zone of transition. The fourth thing that you would see is a matrix. What type of matrix is there in the lesion? Is it ground glass appearance? Is it chondrogenic, or is it osteogenic? The fifth thing that you see is the periosteal reaction. You see the periosteal reaction. Is it a single layer of periosteal elevation which indicates a benign kind of lesion, or is it multi-lamellated like in Ewing sarcoma, or is it a hair on end or sunburst appearance like in osteosarcoma, or a Codman's triangle which indicates a very, very aggressive and malignant tumor? The sixth thing that you see is the size of the lesion. Some of the diagnosis depend on the size of lesion, like between osteoid osteoma and osteoblastoma. Osteoid osteoma is less than 2 centimeters, whereas osteoblastoma is more than 2 centimeters. The seventh thing that you see is the cortical involvement. Type of cortical involvement. If it is an endosteal scalloping, then it indicates a benign tumor. Also look for a pathological fracture. So these are the 7 characteristics that you should see in a tumor, and based on these characteristics and along with the vignette, you should be able to get the diagnosis even if you don't pick up the tumor immediately as soon as you see the X-ray. So therefore you can work hard when you during the exam. Make sure you're picking up the right diagnosis for this lesion or X-ray or image they put up, and I'm sure you will do very well. So in future videos we will discuss a few questions about how to exactly go about dealing with these questions. This is Plexus Ortho. My name is Dr. Kanan Kumar. Thank you very much.